Hi, everybody. Good afternoon. Good morning, as if you're in the three Western provinces. This is Martin Trotter. I'm the president of the Canadian Association of Pathologists, and I'm talking to you from Calgary today. So on behalf of Cancer Care Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, welcome everyone to today's National Pathology Education session on reporting colorectal adenomas and serrated polyps. Just to note that this webinar is not a formal CAP checklist session, so it's an education session, a national education session. So before I go ahead and introduce Dr. Driman and we get going, we just need to go through a few housekeeping issues. Just to remember, the session is being recorded and will be available to all participants. The email links when the recording is ready. That's the live presentation now, and the recorded presentation, if you come back to it later, are eligible for CME credit. Information for obtaining those credits was provided previously in the previous distributions. Just remember that these sessions, the valid credits, they're only up to 1 month after the presentation date, so keep an eye on the dates. Just refer to the session notice for the exact deadline dates. Also note that your line is automatically muted, so you can't be speaking while Dr. Driman's talking. There are a large number of participants, as usual, for these sessions, and it can be difficult troubleshooting WebEx issues in that situation. So if you are having difficulties, the support line was supplied previously in your emails. It's, I'll say it quickly, 1-866-29-339. And of course, there'll be questions allowed during the session. The way to do that is to submit the questions at any time during the presentation using the chat button on the meeting center that you're watching. Documentation before described how to use that. When you do post questions, remember to type the institution's name, individual's name, posing the question, and then the question. And when it's finished, question and answer portion of the presentation, we'll have one of the cancer staff members pose the submitted questions on your behalf in the order in which they're received, in order so we don't have collision of questions coming in, overlapping each other. Okay, let's get on to the housekeeping. So it's now my pleasure to introduce Dr. David Driman, today's speaker. Dave graduated in medicine from the University of Cape Town in South Africa, and then did his residency training in anatomic pathology at Queen's University and the University of Toronto. And he did fellowship training in gastrointestinal pathology after that. He worked in London, Ontario for the past 20 years and is a professor in the Department of Pathology at Western, cross-appointed in the Department of Surgery. Main areas of professional interest revolve on postgraduate education and the of GI, liver, and pancreas pathology. He past director of the AP residency program at Western and past chair of the Royal College AP Examination Board. David's won many awards and is the recipient of the Schulich School of Medicine and Dentistry Postgraduate Award of Excellence and the Department of Pathology Award for Resident Teaching. He's extensively with the Canadian Partnership Against Cancer and Cancer Care Ontario on development in several areas of GI pathology, and chairs the partnership's working group on guidelines for colorectal polyp reporting. And he's the current Cancer Care Ontario regional pathology lead for the Local Health Integration Network, number 2 in his area. He's chair of the partnership's colorectal cancer expert panel and the Canadian representative on the American Pathologists Cancer Protocol Review Panel. So today, David will be presenting on reporting colorectal adenomas and serrated polyps issues for pathologists. David, please go ahead.
Thanks so much, Martin. I appreciate that. And good afternoon and good morning, everybody. I have relevant disclosures to report. The reason about polyps is, as you know, almost all colorectal cancers arise from polyps. And moreover, molecular studies have shown us that there are two broad types of colon cancer. There's microsatellite unstable colon cancer, and there's microsatellite stable cancer. Treated by two different polyp types, assays leading to the MSI-associated cancers, and regular or conventional adenomas leading to the satellite stable cancers. So in this 45 minutes to an hour, I'll talk about these two polyp types, concentrating on practical issues and areas of difficulty or controversy, with secondary aim of improving standardization of terminology for these lesions. Colorectal cancer screening programs are now in place in every province and territory in Canada, and a key goal of these is to detect precursor lesions. Programs also allow for the institution of quality standards, formal guidelines and audits, as well as use of standardized, uniformly applied, and the use of standardized, uniformly applied terminology obviously enhances this, and hopefully that's what I hope to enhance with this talk. This was rationale for the development of the CPAC classification of benign polyps back in 2011. So what I'd like to do is I've divided the talk essentially up into two halves. The first half will be on conventional adenomas, and then the second half will be on serrated polyps. And the first half, what I'd like to address with regard to adenomas is discussing advanced adenomas, i.e. assessing velocity and grading dysplasia. Talk a bit about high-grade dysplasia versus intramucosal carcinoma. Talk about pseudoevasion, and then what we as pathologists need to do when it comes to reporting malignant polyps. So when you come across adenomas, which I think most of us do with great regularity on a daily basis, there are some fundamental things that we need to do. And the first is to assess whether it's a malignant polyp. In other words, is there invasive adenocarcinoma within the polyp? And then the second feature that we need to assess is Dysplasia, and is there a significant villus component? Because both of these, i.e. the presence of any significant villus component or dysplasia, make a tubular villus or a villus or a tubular villus adenoma an advanced adenoma. And patients with advanced adenomas subject to shorter surveillance intervals compared with non-advanced adenomas. For example, colonoscopy at 3 years instead of the standard 5-10 years. Start off by talking a little bit about high-grade dysplasia, distinguishing it from low-grade, and the assessment of villus components in these polyps. So, however, a disclaimer of sorts, and we know from two recent studies, one from Cleveland and one that we did, a couple of our trainees, Alison Osmond and Hector Lee Chang, did, that there's significant intra-observer variation when it comes to reporting velocity in polyps, as well as the assessment of dysplasia grade. Both so-called expert GI pathologists and general community pathologists have a hard time interpreting these things. And as you can see here from these kappas in the Cleveland study for assessing villus change and for assessing high-grade dysplasia, as well as kappas in our study, the degree of intra-observer variation is really quite marked. It isn't surprising to have this degree of intra-observer variation, because fortunately dysplasia in the GI tract, or in fact anywhere, doesn't in fact look like this, but rather like this. So, to alter the statement by William Osler, I'd say that variation in judgment must occur in the practice of an art which consists largely in balancing probabilities. First, is there a significant villus component? In other words, is it a tubular villus adenoma or a villus adenoma? And we all know the various proportions that are required. So, for example, if there is a 75 to 80% villus component, we will call an adenoma or a villus adenoma. If there's less than 20 to 25% villus, we will call it a tubular adenoma. And for those cases in between, those are the tubular villus adenomas. Practice point is that if one happens to know that one is dealing with a large polyp, for example, a polyp bigger centimeter, and one only has small or fragmented biopsies, I think it's reasonable of just one villus to classify the lesion as at least tubular villus, or in fact tubular villus, just to be on the safe side. I'm in a variety of flavors. There are classic villi shown here on the left. You have the long, slender upgrowths, thin stromal cores, often some bulbous tips here. There are the palmate types of villi in which you have clustered, branching, leaf-like structures. And then the more difficult ones, which are the foreshortened type of villi, in which really one is looking for growths beyond the overall surface contour of a otherwise the type of polyp. And these are obviously the ones that have the greatest degree of inter-observer variation. Better to err on the side of underdiagnosis of villus change in adenomas. So if one is dealing with an adenoma that's less than a centimeter, I think it's reasonable, if one's not sure, to err on the side of underdiagnosis. There's often a recognizable form of villus cytology. This is particularly seen with the more classic villi, and they often have these apical mucin vacuoles that you can see in this image here, somewhat similar to gastric foveolar epithelium. I think this is best seen in the classic villi. Second, is there high-grade dysplasia? On to that, I'd like to just briefly go through the nomenclature for dysplasia and cancer in colon. And this image here is obviously of colonic mucosa. And we have an intraepithelial process, so intraepithelial atypia. This we would categorize as either low-grade or high-grade dysplasia, depending on its characteristics. Use like severe dysplasia or carcinoma in situ anymore. There is extension into the lamina propria, so if there's lamina propria invasion, this too is called high-grade dysplasia in the colon. One can refer to it as intramucosal carcinoma, but it's not thought to be a useful term in clinical practice because the lesions are for all intents and purposes, benign. It's when we have extension into the submucosa through the muscularis mucosae that makes a diagnosis of invasive adenocarcinoma with a malignant lesion. So these forms have no malignant potential, and I just want to stress that this applies only to the colon and the rectum. The situation in the esophagus and the stomach is different because in the esophagus and stomach, invasion into the lamina propria is a bona fide malignant lesion, and doesn't form the way the pathology that we use in reporting polyps. High-grade dysplasia diagnosis is partly an architectural diagnosis, and I think that in most cases it can be seen at low power. As in this polyp, you can see here these two areas, which are areas of high-grade dysplasia. So high-grade dysplasia, what one typically sees is architectural complexity. The epithelium looks darker, disorganized, dirty. At low power, there's complex glandular crowding, budding, cribber forming, and these are sort of the classic features of high-grade dysplasia. These spectral findings are usually accompanied by cytological features such as loss of nuclear polarity, fullness, nuclear stratification through the epithelium, atypical mitotic figures, etc. And in the lower panel here, just a typical example of low-grade dysplasia to compare with the high. That's to bear in mind when grade dysplasia, and that is to beware of using cytology alone to diagnose high-grade dysplasia, and the changes are very marked, or one has a small biopsy of a large lesion and sufficient tissue to properly assess architecture. Don't overinterpret cytological changes on the surface of adenomas without architectural complexity, as this is often due to trauma or erosion or prolapse. So don't overcall focal architectural abnormalities. There's often a minor degree of budding into the adenomas without there being high-grade dysplasia present. Dysplasia changes usually involve more than just one or two crypts. I can't give you a precise number for that, but it's usually not just one or two crypts. So the way in which we report these here, we prefer to report the absence of high-grade dysplasia than the presence of low-grade. So, for example, we don't report tubular adenomas with low-grade dysplasia. We report them as negative for high-grade dysplasia and malignancy, and this is done to avoid any interpretative errors on behalf of the physicians reading the reports. If we look at this adenoma here, you can see this very focal area there. I think we'd all agree that this is cribber forming, but this, for me, is way too focal to call this high-grade dysplasia, so I would not mention that in this polyp. This is another adenoma here, in which if we look at this area, one can see that there is full-thickness nuclear stratification. You can see that in this area compared to over here. And again, this on its own is not a feature of high grade. One wants to see the architectural abnormalities as well, and those are not present here. So this I would call a low grade or negative for high grade dysplasia. And again, just to re-emphasize the fact that hyperplasia can be seen at low power in this lesion here. Obviously, this area here is high grade. There's architectural complexity, crib forming. The nuclei here are more atypical than they are here in these low grade areas, and so that's high grade dysplasia. So again, we have invasion into the lamina propria, and you can see the muscularis mucosae here. For practical purposes, we report as high-grade dysplasia because, for instant purposes, these patients are not at biological risk for malignancy. One study that has looked at whether it's still safe to call these lesions high-grade when the intramucosal component is poorly differentiated. So in this study here, one can see they reported 12 cases in which there was invasion limited to the lamina propria, but the component was poorly differentiated. So for example, here you can see signet ring cells, or at least individual cells. Here you have obviously some poorly differentiated areas as well in this lesion. And all of these cases for a median of 13 months, and they found no cases in which there was an adverse outcome in terms of metastases. As a response to that paper, there was a letter from Memorial Sloan Kettering group, and they reported 2 lesions in which their observations were different. So, for example, in this lesion here, there are some signet ring cells in the lamina propria, and in this case, there was recurrent adenocarcinoma after 17 months. And in other cases, they reported the presence of definite lymphatic invasion in a case in which there was intramucosal spread. This is the way that I think one can deal with these lesions. That is that if one has an adenoma in which there is lamina propria invasion only, it's good practice to confirm this with multiple deeper levels. If there is no fully differentiated component, there is no lymphatic invasion or no desmoplasia, one would call this high-grade dysplasia, and it's reasonable to use a comment just to explain the use of the term in that instance, although I think not all pathologists would even bother with a comment in that situation. Any of these features are present. For example, the intramucosal component is fully differentiated. One could put in a similar comment, still calling it high grade, but I think suggesting that it's a little less cut and dried, and that discussion of the patient at a multidisciplinary case conference is recommended. The third important parameter to assess is there a malignancy? Is it a malignant polyp, and can we differentiate malignancy from pseudo-invasion? Malignant polyps are adenomas in which there is invasive adenocarcinoma, and that is diagnosed by invasion into the submucosa. So one can see in this TVA here, this is stalk, and then the submucosa here is infiltrated by these angulated, with an infiltrative growth pattern set within a desmoplastic stroma. I don't think any of us would have much difficulty diagnosing this as a malignant polyp. Malignant polyps, what's our role? Why make the diagnosis? 2, importantly, report those factors that are used to guide subsequent management. In other words, is polypectomy sufficient, or does the patient need resection? And thirdly, to differentiate malignancy from pseudo-invasion. Invasion, also known as epithelial misplacement or mucosal herniation, is when adenomatous mucosa becomes misplaced or herniated into the submucosa, so this region of the polyp. It occurs currently in the sigmoid colon. This is because the sigmoid colon is the most mobile segment. Stool in that area is firmer, the lumen is narrower, and all of these factors lead to these polyps twisting. In our practice, differentiation of pseudo-invasion from malignancy is quite a common problem, and in our consult practice, we regularly see these challenging cases. An expert, the Neil Shepherd from the UK, has said that epithelial misplacement or pseudo-invasion has become the most extraordinary diagnostic that a senior GI pathologist has seen or perhaps recognized in his professional career. Is easy to diagnose when it's classic, and most of these types of talks, one tends to show classic cases like this one. So in this particular case, one can see herniation of mucosa into the submucosa. It's important to recognize that it's whole bits or fragments of mucosa that are being herniated, and so you get crypts with surrounding or intervening lamina propria. These have a rounded contour, not an angulated contour, and the appearance is not haphazard. The degree of dysplasia within these herniated foci is the same usually as it is in the head of the polyp. And just at high power here, you can see the intervening lamina propria. You can see another feature that's very often present is sidrin, and it's just from hemorrhage from the fact that the polyp has previously undergone torsion. Sometimes one can even see ischemic changes on the surface of the polyp relating to torsion. Another classic pseudoinvasion at low power, you can see here the displaced mucosa and obviously lots and abundant hemosiderin. This is a case that we recently saw in our consult practice here, an adenoma with obvious pseudoinvasion here, the lobules, intervening lamina propria, but there was a couple of other areas that caught our eye, like these two crypts here. One of which looked to be partially ruptured. They have a bit of an angulated contour, and we had quite a discussion about whether this could be invasive adenocarcinoma arising in a polyp that also had pseudoinvasion, and that certainly does occur. Mucin pools are okay in pseudoinvasion, provided that they have a smooth, regular outline, and they are lined by epithelium that is similar to the epithelium elsewhere in the polyp. One does not want to see is irregular, jagged mucin pools sort of dissecting the stroma, and one doesn't want to see cytologically malignant cells floating in the mucin. But of course, there are numerous problems and pitfalls, and pseudoinvasion is often not easy to diagnose. If the polyp does have high-grade dysplasia, which is misplaced, or there's an extravasation with secondary inflammation and stromal reaction. If there's been previous biopsy that may have elicited a stromal reaction. And often in cases of a previous biopsy, one can see mixed normal mucosa, i.e. non-dysplastic mucosa, with plastic mucosa in the herniated components, and that can be helpful. Pseudo much less common in rectal polyps, unless there's been some previous intervention. So I always like to think twice about pseudoinvasion in rectal polyps, just to make the point that one should be very liberal with the use of deeper levels, if not cutting through the entire block to try and deal with the issues. And then a lot of this adenoma section is just to talk about malignant polyps and the factors that determine polypectomy or resection. So the factors that we have to report are those that guide further management, and this requires balancing the risk of operative mortality. We can see here overall is about 3 to 5%. Older individuals over than 80 have about a 15% average mortality compared with 1 to 2% in younger individuals. Risk of adverse outcome in terms of finding residual malignancy in the bowel or positive lymph nodes, and pathological determination affects this. For example, resection margin status affects risk of residual malignancy, and tumor grade, as well as these other factors, affects the risk of nodal positivity. It's very much a balancing act, and the patient's risk tolerance is a feature that has to be considered by the surgeon. So, margin status affects the risk of residual or recurrent malignancy. A positive margin is regarded as tumor extending to less than 1 millimeter from the stalk margin. In this recent study, we can see here that they found a 60% risk of residual or recurrent cancer in margin-positive cases, 0% if the margin was negative, and curiously, actually, a higher percentage, 21%, in those cases where the polyp couldn't be properly oriented or being resected in a piecemeal fashion. So risk margin distance is important. With regard to lymph node involvement, these are the factors that are key: tumor grade, lymphovascular invasion, presence or absence of tumor budding, and extent of submucosal invasion. Budding is the presence of isolated tumor cells or clusters of cells at the advancing edge of a tumor, represents tumor dedifferentiation. One assists tumor budding by looking at low power at the invasive front, looking for blowing of the tumor stroma interface, and then assessing number of groups of cells. So in order to count tumor budding, one looks for groups of cells, less than 5 cells, and then if there are greater than or equal to 10 such groups, that is tumor budding positive. What is the extent of submucosal invasion? Consideration of the Haggard and Kikuchi levels helps inform us about the risk of lymph node spread based on the principle the number of lymphatic channels increases as one progresses deeper into the bowel wall. So, for example, Haggard level 1 to 3 cancers in the head or the stalk of a polyp, have a very low risk of nodal spread, as you can see here, lower than the risk of the average mortality from surgery. If the tumor is into the submucosa at the level of the underlying or adjacent bowel wall, the risk increases, shown here by the Kikuchi levels. So inner third submucosa, middle third, outer, there's a progressive increase in risk of lymph node spread. The process assessing both at and Kikuchi levels is that these are very difficult to apply in practice. Kikuchi is impossible to apply in practice unless one has muscularis propria, so that's usually out. And for this reason, estimation of the extent of submucosal invasion by measuring the depth of tumor spread from the muscularis mucosae greater than 2 millimeters, and lateral extent greater or less than 4 millimeters has been shown by UNO to be a very useful factor. And you can see here from the data from the study, cells width less than 4 millimeters, 2.5% positive lymph nodes compared with 18 if it was greater, and similarly here for the depth of submucosal invasion. Altogether, if one has a tubular villous adenoma with malignancy or a villous adenoma with malignancy, assess the resection margin. In most cases, a positive margin will lead to surgery. Any of these factors present, tumor high grade, tumor budding present, lymphovascular invasion, extensive submucosal invasion, any of those patients will generally have surgery, and if any, they're all absent, polypectomy. But as previously, it's a balance. Patient age is key, and I think that all of these patients should be discussed at a multidisciplinary case conference. So, moving on to serrated polyps. Back in the 50s, 60s, and 70s, life was pretty good. We know that, so we knew at least that this was hyperplastic polyp, didn't cause colon cancer. This was a villous adenoma that did. And then the 80s and the 90s and the 2000s came around, and evidence began to accrue that things weren't quite what they seemed. There were numerous reports associating hyperplastic polyps with cancers, reports of giant or atypical hyperplastic polyps that harbored dysplasia and cancer. And then we had the reports of the new lesion, the serrated adenoma in 1990, followed by reports of SSA and TSA in 2003. And they had reports of SSAs next to cancers and even SAs with invasive cancers. And we, of course, realized that this lesion is in fact not a hyperplastic polyp, but it's an SSA and causes about 20 to 30% of all cancers. And a lesion like this is in fact a TSA, which also leads to cancer. So these are three types of serrated polyp that we encounter in daily practice: the hyperplastic polyp, the SSA, and the TSA. With regard to SSAs that have dysplasia, I recommend not using qualifying terms like cytological or conventional, but simply dysplasia, because I think there's anything to gain by complicating the terminology with the use of those additional terms. So we report these as plus or minus dysplasia, reporting it is either low or high grade. And then for TSAs, because they all have some degree of dysplasia for the most part, we treat them like adenomas, plus or minus high-grade dysplasia. We use the term serrated polyp unclassified for those cases where we can't make up our minds. And then, of course, there is the weird serrated polyp with features of HP, SSA, TSA, and regular adenoma in improbable combinations. We've all seen these, and can be nicely abbreviated as follows. Of course, for whether we should call them SSAs or Ps or even SS lesions, as they like to call them in the UK, there is no one absolutely correct term. Unfortunately, the four most recent GI textbooks don't help us much. The term SSA/polyp is a democratic one and is useful in the textbook or in a paper, but in practice, I think a single term is best, and we use SSA, and my sense is that it's becoming the preferred term, at least for reporting. Some of the rationale for this is explained here by Dr. H.L. in his interaction with Dr. R.I., who asks, do SSAs have dysplasia like other adenomas? No, they don't. Then we call them adenomas. I thought all adenomas had dysplasia and look like tubular adenomas. No, they don't. In the GI tract, we have hepatocellular adenomas and pyloric gland adenomas, which don't look anything like tubular adenomas. Actually, we regard SSAs as having architectural dysplasia, so that makes us feel okay calling them adenomas. But importantly, they are pre-malignant, like other adenomas. I see. And SS polyps or lesions might confuse you, and you may not want to remove them. These hyperplastic polyps, these are serrated polyps that have serrations in their luminal or proximal or lobes. The crypts are straight, the bases are narrow, and there are mitoses in the lower third or the lower half only. I've had two different types of hyperplastic polyp. There's the microvesicular one, in which the cells have have bubbly vacuoles in them. This is the commonest type of hyperplastic polyp. And the other type, which is the goblet switch type, in which you have pretty much only goblet cells, and these occur much more frequently in the distal colon. Subtypes is not recommended. They also have different mutational associations. For example, microvesicular polyps, like SSAs, are associated with BRAF mutations, whereas the goblet cell polyps are associated with KRAS mutations. Polyps also often have thickened subepithelial collagen, maybe not demonstrated to its best in this image, but this can be helpful in distinguishing them from SSAs. The classic SSA, it's sile, it's submucosal fat, it has some dilated crypt bases, it has horizontally spreading and funny-looking crypt bases, it has exaggerated deep cryptations, it has abnormally located differentiated cells at the base. And as you can see, this is sort of gastric or mucinous differentiation here in hyperplastic polyps. deep abnormalities, it's all about bowling pins, boots, and anchors. And so some SSAs have these dilated crypts. Others have these anchors where you can see these upward projections here, which are common. And there are other polyps that have more of a boot shape. There are upper crypt abnormalities, which we can see if we look for them. So subtly enlarged nuclei, vesicular nuclei, prominent nucleoli, and upper crypt mitoses, which are not seen in hyperplastic polyps. The slide, or the idea for the slide, was given me by Rich Pai, and this shows one of the fundamental differences between hyperplastic polyps and SSAs. In hyperplastic polyps, the proliferative zone is at the base of the crypt, which is why the crypt cells at the base often look darker, and maturation is upward. In SSAs, the proliferative zone is shifted luminally, and one has maturation in two different directions. Minimal criteria for diagnosing an SSA. So the WHO Blue Book says 2 or 3 contiguous crypts. In a more recent authoritative consent paper, this is the definition that was put up there. So 1 unequivocal, architecturally distorted, dilated, and/or horizontally branched crypt, especially with inverted maturation. If you're uncomfortable with this definition, after all, one swallow doesn't make a summer. A large population-based study from Australia has corroborated the validity of this more permissive definition. Looked at almost 3,000 serrated polyps, and they showed in this series that the presence of even a single crypt, those patients had features that were clinically much more like SSAs than hyperplastic polyps. The study from Australia looked at the breakdown of colorectal polyps, and they found that almost half of all their polyps were serrated. And as we'd expect, hyperplastic polyps and TSA is common on the left side, SA is on the right side. The hyperplastic polyps on the right side actually surprised me a little, because it was more than what we diagnosed. So I looked at some of the serrated polyps reported by myself and another pathologist in our group for 3 months last year. And as I thought, we don't ever, but we seldom make a diagnosis of a hyperplastic polyp on the right side, as you can see here. Left-sided serrated polyps with equivocal features, I always advise one to think twice about diagnosing a hyperplastic polyp, especially if the polyp is big, anyway unusual. I think it's not sure. I think it's better to use the term serrated polyp unclassified with a comment to explain that the features are equivocal and the correlation with endoscopy is needed. And I think that these patients should probably be managed as if the polyp was an SSA, especially if it's bigger than a centimeter. Top lesion here, I wouldn't have any problem calling this an SSA, even though it's not optically oriented. This bottom one, I think, depend on the day, but I would likely call it an SSA or an FPU. I would never call a polyp like this from the right side a hyperplastic polyp. SSAs often have some confound features, so that the crypts, as I mentioned previously, can show a mixture of deep serrations and dilations. They have features recognizable as hyperplastic polyp within them, which is actually not unexpected because many investigators think that these arise from microvesicular hyperplastic polyps. Some even contain features that one would probably call TSA-like. problematic polyps that we have here in London are the bigger left-sided polyps that look like this. These are the polyps that tend to drive us crazy, and they have some exaggerated serrations. But what also often have is they have this smooth muscle proliferation here, and this is to say mimic, and it's a hyperplastic polyp that has prolapse changes, and these changes can cause the base of the crypt to look more complex and serrated than they otherwise might do. This has actually been studied, and so there's this study that for histological analysis and also looked at BRAF mutations, and what they did was they actually reclassified 33% of rectal polyps that had been diagnosed as SSA or HP with features of SSA as plastic polyps with prolapse using careful analysis and BRAF mutations. Is to look for these features, which are essentially the features of prolapse, particularly thickening and reduplication of the muscle layer, fibromuscular obliteration of the lamina propria, and when one can see dilated, particularly diamond-shaped crypts at the base. Any ancillary test that can help us. There was a time when it was thought that MUC6 could be useful, but that's been shown not to be the case. The immunomarker ANGSA10, which looks potentially useful, has been shown to have reasonable sensitivity and specificity in the diagnosis of SSA, but as far as I'm aware, no one is actually using it practically. The significance of SSAs is that they give rise to cancer, and thought that at least some rise from microvesicular hyperplastic polyps with the involvement of BRAF mutations, as the presence of methylation increases over time. ML1 becomes methylated, becomes lost, microsatellite MI high develops, and then you have the appearance of dysplasia, and then adenocarcinoma. And to do MLH1 in an assay with dysplasia, you'll see retention of the MLH1 in the non-dysplastic component and loss in the dysplastic component. This is how to think of the progression to cancer of the various polyps. So it's said that it takes an adenomatous polyp about 10 years to become cancer, so a nice country road. An SA, dysplasia, an urban street, and an SA with dysplasia, a highway. Examples, this is an SSA with a plastic component here in the top right. So classic SA here and conventional looking dysplasia over here. This is not a mixed hyperplastic polyp tubular adenoma. This is an advanced SSA or an SSA with dysplasia. A lesion which has areas of SSA as shown in this top panel, as well as areas of adenoma in that area and another SSA with dysplasia. This polyp here, this bigger polyp, has a few different areas. Over here, it has typical features of SSA, and over here, it has some features that one might even want to call TSA-like because of the serrations. And I think this probably represents a different form of dysplasia, TSA-like or serrated dysplasia, as opposed to the more conventional or tubular adenoma-like dysplasia. I think you can see both types within SSAs. There's an SSA here which has dysplasia and in fact also has a focus of adenocarcinoma. There are polyps like this which also tend to drive us up the wall. A polyp that for all intents and purposes looks like a true mixed hyperplastic polyp SSA. We've all seen these, and we all battle with what we call them, knowing that we are not meant to call mixed hyperplastic polyp assays. The TSAs, the classic features of a TSA are the ectopic crypt foci or the ectopic crypt buds, the eosinophilic cells with pencillate nuclei, the very rigid, sharp serrations, and dysplasia. I think they all have some degree of dysplasia, although it's not always, one can't be sure which foci are dysplastic and which aren't. TSAs have different mutations, so there are BRAF mutations, and up to half have KRAS mutations. I think these TSAs are quite enigmatic, and we know a lot less about them than we do SSAs. Variable types of morphology of dysplasia, so this obviously more recognizable, conventional type dysplasia, and then others that have the more clear cell change or the more gastric type features. I think what happens in these TSAs and what makes them look, in some instances like TVAs, is that as the dysplasia increases, the TSA features with numerable recognizable ectopic crypt they change and they look more like tubular villus or villus adenomas with increasing dysplasia. Example of a TSA here, many areas look like this with lots of ectopic crypti and rigid serrations, and areas that looked ostensibly like a conventional tubular adenoma. An example here of a TSA with high-grade dysplasia and adenocarcinoma with some mixed morphologies. So this area here, there's sort of clear cell gastric type morphology, again, rigid serrations. This area here, the more typical TSA with lots of buds, and the other areas like this with what we call more conventional dysplasia and then invasive adenocarcinoma. These features are now well recognized, and a variety of recent studies have shown that up to 50% of TSAs can have foci within them of hyperplastic polyp and SSA. So the presence of a small focus of HP or SSA within an otherwise typical looking TSA should dissuade us from making that diagnosis. I like to report TSAs like I do regular adenomas, so just negative for high-grade dysplasia and malignancy, and SSAs negative for dysplasia and malignancy or with dysplasia. And I usually like to put in a comment with the advanced SSAs to say that these have an increased propensity to transform to malignancy, and just emphasize that complete removal is recommended, and if it cannot be achieved, section should be considered. The only ones that have with, particularly with SSAs, and it's been inferred from a couple of studies that substantial numbers of endoscopists miss serrated polyps in the proximal colon. And not only do they miss them, but they are also difficult to completely excise. And one can appreciate why from these images. So, for example, this SSA here that is highlighted with an imaging, which is to show the vascular cutoff that is often present. But you can imagine how difficult it would be to know if one has completely excised this lesion. Similarly with this SSA, which really is just a subtly swollen fold. Classic endoscopic appearance is this mucin cap, which is due to the mucin production on the surface of SSAs. The difficulties in assessing them endoscopically is important because it's been shown that SSAs or incompletely resected SSAs are certainly the cause of interval colon cancers. In other words, colon cancers that arise with a few years of index colonoscopy, i.e. within the typical screening period. Colon cancers are right-sided, have MSI status, and have SIMP status, which is the same, which essentially correlates with cancers that arise from SSAs. And this goes along with the fact that we know that the risk reduction in colon cancer incidence for colonoscopy is much more effective on the left side than it is on the right side. Management of serrated polyps is to completely remove them endoscopically, except for multiple tiny polyps on the left side, because these are almost always hyperplastic. They cannot be completely removed, or they've been removed in a piecemeal fashion. It's advisable to re-endoscope these patients in 3 to 6 months, and if they cannot be removed endoscopically, or the patient has multiple large lesions, then surgery should be considered. My final slide, I'd just like to mention the situation in which we receive polyps, or we receive biopsies of polyp, but don't see a polyp in slides that we get from the lab. And this is a study done by Brian Schick, one of our residents, who looked at 214 of these cases. So in other words, the biopsy comes in as a polyp. We didn't see any polyp on our standard sections, which includes 3 different levels on 3 different slides. And for the deeper levels, and these showed that in a quarter of the cases we found a polyp, and in 3/4 of those, the polyps were adenomas. One can argue about the merits of finding such tiny adenomas, but I would still suggest that when biopsies of a polyp fail to show any evidence of a lesion in your standard sections, that you consider cutting deeper levels, because you may very well find a lesion. Thank you much, and I'll be glad to take any questions.
So, Dr. Driman, we're waiting for questions to come in. Just send a reminder to the participants that you can use chat feature to submit your questions to Dr. Driman. Be sure to include your institution's name, the name of the person posing the question, and finally your question. So we have a few that have come through already, so we'll go ahead and get started. The first is from Dr. Jackie Borges from Cambridge Memorial Hospital. Her question is, report anything about involvement of the base of the polyp with low-grade dysplasia? And if so, how would you report that?
I think the question is probably referring to resection margin status. In other words, do I report the resection margin status in polyps? And the answer is no, I don't. Here in London, we only report resection margin status for malignant polyps. If the polyp has high-grade dysplasia, if I'm able to, and I might say that the high-grade dysplasia is not at the polyp margin, then regular adenomas, no.
Thank you. The next question is from Dr. Marcio Gomes from Ottawa, Ontario, and is asking if you could please comment on step sections of the following situations. The first being one sent as a polyp, no histological changes seen that justify a polyploid lesion.
I would definitely do levels. I'm not sure if step sections are the deeper levels, but in a situation, I would get additional deeper levels on such lesions.
Okay, next would be high-grade dysplasia in a large polyp.
No, I don't get additional sections for high-grade dysplasia. I think if the high-grade dysplasia was very extensive within a polyp and I was concerned that some areas maybe look like a high-grade dysplasia, and I might get some levels, but for sort of standard high-grade dysplasia, I don't really get levels.
One more question or comment from Marcio is, you're malignant in the distinction of high-grade dysplasia and invasive carcinoma might be confusing, and wonders about the terminology of using risk of progressive disease instead. And any comments on that?
Yes, I agree, and I think this has to come up with events that make sense to one's practice, and which makes sense to the clinical things that one is working with. Sometimes it's even useful to run these comments by them to some input, but yeah, that's reasonable, yes.
Our next question comes from Dr. Raymond Mung from Royal Inland Hospital, Kamloops, British Columbia. And the question is, can you use M1B1 to differentiate HP versus SSA?
I'm not sure what M1B1 is.
Could it be MIB1? I'm not sure if there's a...
Oh, MIB1, MIB1 or Key67. What was the first part of the question?
Can you use
distinguish
MIB1 to different, HP versus SA?
I don't think so. I don't think Key67 would be viable in that situation. I don't think there's real differences between the way I would state it between the two pops and how they'd stain. I don't think so.
Okay. The next question comes from Chinook Regional Hospital, and the question is, how do you distinguish between an SSA with dysplasia and a T showing gland serration?
That is a situation that does arise from time to time. In other words, what is being referred to is sometimes one can have a lesion that looks for all the world like a tubular adenoma, but in some areas they have a serrated look to them. I don't really have a good and applied answer to that. I think it would probably depend on the overall appearance. I think even how extent the serrated change is, and a variety of features. So I think when I sort of look at the entire lesion and synthesize the various features that are present, I don't have a pat kind of way to separate those. Suffice to say that I think it's definitely unusual to have an adenoma with serrated features. So I'd always think twice about making that diagnosis, especially if it's on the right side.
The second question from the same site is, are there any difference in the management between serrated dysplasia and traditional dysplasia in SSA? Does dysplasia need to be reported?
I don't think there's any difference at this time. I don't think we're sufficiently advanced in our knowledge to do that. And so no, not at this time.
Next question again comes from Dr. Raymond Monk from RH. And the question is, if you have multiple polyps sequentially or at one sitting, do you comment on possible hereditary conditions?
Yes, I do. So I think if there's more than 5 SSAs, then I would definitely raise the option or raise the possibility this patient has serrated polyposis. We in fact had a case like that just a couple of weeks ago in which we did that.
The next question comes from Dr. Amir Samani from Brampton, Ontario. And the first question is the polyp shows high-grade dysplasia and desmoplasia, or isolated cells, but no muscularis mucosa seen. How do you report this?
Carefully. I think that if you see desmoplasia, you have to be very concerned that there is invasion, because I think that the presence of desmoplasia is a marker, if you will, of malignancy, of submucosal invasion. So I think in those polyps where one doesn't have a nicely oriented lesion such that one can see the difference between mucosa and submucosa, I think the presence of atypical glands associated with desmoplasia is malignancy. So I think one has to be very careful with those lesions.
Thanks. The next question comes from Dr. Rosemary Henderson from Queen Elizabeth Hospital, Charlottetown. And do you find a combination of CK20 and Ki67 useful in distinguishing HP from SSA?
No, I haven't. Similar to the previous question, I don't have much experience with using CK20 in that situation, or even CK20 and Ki67. So I can't comment from a point of experience. I don't know.
Thank you. The next question comes from Dr. Lung in Toronto, and the question is, does TSA like serrated dysplasia in an SSA have the same implications as conventional dysplasia in an SSA?
I think as far as we know at this point, I'm not aware that there's a difference in the way in which that polyp will behave or in management of the polyp. I don't think there is. I think also likely the observe a variation in assessing those two different types of dysplasia would be quite high amongst pathologists. So at this point, no, I don't think so.
Thank you. The next question is from RH in Edmonton. And the question is, do you use the same criteria for extensive invasion in pedunculated and style polyps?
Essentially, although I think the criteria I talked about, so the extent of submucosal invasion is a more useful criteria for sessile polyps or for fractures of a polyp in which one doesn't have good orientation, such that one can really assess whether it's truly pedunculated or sessile. Classic pedunculated polyp in which one has a stalk and one can see, essentially one can see the Haggett level. I think the of submucosal invasion criteria are probably not needed.
Thank you. Our next question comes from Dr. Samani in Brampton, Ontario. The question is, D240 stain shows lymphovascular channels in lamina propria in the colon. Does it change our approach to high-grade dysplasia / intermucosal carcinoma?
In fact, there are lymphatics in the mucosa, but they are few in number, they are sparse, and they are very much basal. So even with that knowledge, studies have shown that they should be considered as not significant, ostensibly. So no, don't. The fact that we know that there are lymphatics in the mucosa doesn't change the fact that we should not be reporting intramucosal spread as malignant.
The next question is from Miriam Horadula. And the question is, as I understand, we call villus adenoma as high-grade dysplasia if there is cytogenetic atypia or invasion to lamina propria. Is this correct?
Sorry, can you restate the question?
I think they're asking if their understanding is correct. So they call villus adenoma as high-grade dysplasia if there is cytogenetic atypia or invasion to lamina propria.
Yes. So if there's invasion in the lamina propria, and no invasion into the submucosa, one would use the term high-grade dysplasia, or a tubular villus, or a tubular adenoma.
I think this is from Dr. Bijadi, and the question is, if you're not sure cancer is in the submucosa in the biopsy, and there is desmoplasia, what is your recommendation?
There's true desmoplasia, and there's an infiltrative appearance to the glands. It's invasive adenocarcinoma. So even if one doesn't see the anatomical distinction between mucosa and submucosa, dysplasia is a marker of mucosal invasion. Possible exception, although I think this doesn't occur very often, is if there's been some form of previous procedure that's incited a response. But true desmoplasia, one can call it invasive adenocarcinoma.
This question is from Dr. Sami from GEHA. How would you distinguish mucin pools of mucinous carcinoma from pools of mucin with high-grade dysplasia in the abscess of a suspended cancerous polyp?
So I think the question is get the distinguishing pseudo-invasion with mucin pools and true invasion with mucinous adenocarcinoma. So with invasion type mucin pools, the mucin pools have a rounded edge. They are not jagged. They don't have an infiltrative, irregular pattern within the stalk. The mucin pool associated with pseudoinvasion can be partly lined by cells, but the cells should not be cytologically malignant, and they should look the same as the adenoma cells elsewhere in the polyp. Are cytologically malignant, different, that would sway you much towards mucinous carcinoma.
The next question comes from Dr. Jennifer Ramsey from Hamilton, Ontario. The first question is are levels really required for routine polyps?
That's an interesting question. I know the definition of really required, but it is our standard practice here in London to get 3 levels on all of our GI biopsies, including polyps. And certainly the study that Brian Schick did suggests that is definitely needed because, in those cases where we don't find a polyp, we will often find them with additional levels. We did do a survey of pathologists, of some pathologists across Canada a year or 2 back, and there was some variation in practice between, how many levels people do, but levels seem to be a fairly standard way of handling GI biopsies.
Dr. Ramsey's next question is regarding whether or not you have insight into whether tumor budding is coming to synoptic reporting.
I don't have any insights, but I'm pretty sure that it will be coming to a synoptic report near you soon. I hope it will be.
Thanks. Our next question is from Dr. Helwani from Ottawa Hospital. The question is, what do you call a polyp with all the features of SSA, but in left colon?
SSA.
Thank you.
So in other words, SSAs occur in the left colon and the right colon. They're much more common on the right colon, but they definitely occur in the left colon, and don't be dissuaded from diagnosis in the left colon, but beware of the mimics, particularly hyperplastic polyps that are associated with prolapse.
Thanks, Driman. Those are all the questions that have come in. So with that, I will hand it back to Dr. Trotter to close us out.
So on behalf of Cancer Care Ontario and the Partnership Cancer and the Canadian Association of Pathologists, I'd like to thank Dr. Driman today for a very comprehensive, informative, beautifully illustrated and clear presentation. Thank you, David. Just remind people, this is the fifth session of the 15 series CAP Checklist Education Series, and remember to fill out your feedback. We certainly welcome all comments and suggestions of how we can ensure these sessions are informative and relevant to your pathology practice. So, please include your feedback and suggestions as part of the online evaluations. And a reminder again that once the recording is ready, the links will be posted separately, and you can access this recording when it's available and review it again at your convenience. And of course, for those who haven't already claimed credits for this live presentation, any credits are available for the recorded presentations, and you can claim those. And other thing to remember, just one more time to remind you that the credits are only available for 1 month from the presentation date. Even though the recording might be available longer, the CME certificates will only be issued for 1 month. So just keep an eye on that. And just to sign off, remind that our next session is on April the 8th, Wednesday, April 8th. Next month, Dr. Gupta from Kingston speaks on breast core needle biopsies, diagnostic challenges, and controversies. So thank you very much, everyone, for your participation and active question and answer session. And thank you again, David.
Thanks.